So welcome everybody. My name is Sanjoy Bhattacharya. I direct the WHO Collaborating Center for Global Health Histories at the University of York. So this is the World Health Organization Global Health Histories Seminar 138. I know John from many years, and when I first met John, the Global Health History Seminar series was just getting off the ground. I don't think any of us in the WHO or outside the WHO ever thought we'd get to number 138. So I'm delighted we're here today. Today's event is also supporting the WHO Regional Office for Europe's Culture and Health webinars. And we remain grateful to the Wellcome Trust for its support. It has supported almost all of the WHO Global Health History seminars that have been held so far. We have two speakers today, Dr. Namrata Ganneri, who will speak first. She is a Commonwealth Rutherford Fellow based at the Department of History and is currently completing a book, which I'm honored to co-author with her, on smallpox eradication in India during the 1960s. We also have Mr. John Wickett online. John is a retired WHO official. He's the man who gave me access to the WHO's wonderful archives in smallpox eradication, for which I remain eternally grateful. But most importantly, John was the person in charge of logistics that made smallpox eradication possible. We often think about the vaccine, we think about training, we think about other forms of social engagement, but one thing that's often forgotten is how to mobilize such a complex program. And here is the person who was the sort of person who kept all the ends connected, made sure everyone got what they wanted during a complex program, and I'm sure you will learn a lot from John. We are very grateful to a number of people for helping us organize an event. These events are always complex, needs a lot of preparation. There'll be a lot of work afterwards, for which I apologize to Arnab already. And we are grateful to three people in the WHO Regional Office in Copenhagen particularly for their support, although there are many others who also help us. Priya, Liliana, and Niels have been a wonderful source of support in organizing this event. Arnab, my colleague at the Center for Global Health Histories and WHO Collaborating Center, has done a lot of work. And Steve, for answering numerous emails from our wonderful AV Center. So Namrata, can I invite you to come and speak first, and then John. Thank you so much for joining us.
According to historian Nancy Stepan, smallpox eradication took a very long time or a very short time, depending on one's point of view. On the long side, we have almost 200 years before the discovery of Jenner's smallpox vaccine in 1796, followed by the end of certification in 1979, which we are commemorating today. On the short side, we have views of institutional histories, chronicles, smallpox warriors, who mainly emphasize the intensified efforts of 10 years between 1967 and 1977 as critical to the success. But if we cast our eyes onto the preceding decade, and I would argue it is no less important because, not least because of the launch of India's campaign against smallpox, which at that time was the biggest campaign in the world. The possibility of eradication was endorsed by the World Health Assembly in 1958. The vaccine was standardized in 1958. And finally, a reference vaccine was also established only in 1962. A definitive statement synthesizing available information about the disease as well as strategies of eradication emanated from the WHO only in 1964. This was called the Expert Report on Smallpox. The committee comprised of members from many nationalities, and a prominent member of this committee was Dr. K.M. Lal. Dr. Lal brought to the committee his experience of running the Indian National Campaign. In 1964, the campaign was already 2 years because it was launched in 1962 after conducting several pilot projects in 16 districts, which informed on the challenges of running this crash campaign. The Indian experience overwhelmingly fed into the views of the committee, and there are many references that indicate this, but I will flag mainly 3. A revised mass vaccination strategy of vaccinating 100% of the population. Vaccinating 80% of the population, which it was believed was enough to give herd immunity, hadn't yielded much results in India, and therefore by 1964 the campaign had revised its targets to vaccinating 100% of the population. Family registers, which recorded histories of all the members of the household and their vaccination histories, were seen as central to future social and public health campaigns. By the way, this was a much ridiculed component of the Indian program, primarily because it was time consuming. But most importantly, in the recommendations section, we have a reference to concurrent evaluations, simultaneous evaluations of the program that were done mainly to improve the efficiency of the program. The Indian program had conducted pilots, evaluations in 5 districts. You can see those 5 districts named over there on the Indian map. And following these pilot evaluation studies, a definitive manual was published. This manual, which is also the cover page is here for all of us to see, was commended in several contemporaneous WHO publications. To cite just one example, the official organizational history of the second 10 years of WHO, which was published 1958-1967. Lal seems to have become an important face of the unfolding global program, since he was appointed in a 3-member committee to obtain first-hand information about national smallpox eradication and control campaigns in Afghanistan, Burma, Congo, Mali, and Nigeria. The other 2 members of this committee were Dr. Almeida Rodriguez from Rio de Janeiro and the Japanese Dr. Isao Arita, who was with the Virus Diseases Division of WHO and who, as many of us know, eventually went on to head the WHO Smallpox Eradication Unit 1977 through 1984. It was believed that the observations of this 3-member committee would inform the subsequent global strategy. The news of Lal's participation in this committee is reported in glorious terms in the Indian publication Swasth Hind, which was a mouthpiece. Swasth Hind, translated as Healthy India. You can see the table of contents over here. And this was the mouthpiece of the Ministry of Health. Though it is important to note that this committee was mentioned only in passing in the official WHO history, the Big Red Book. Lal retired from his position in 1966. The Indian campaign ran out of steam in 1967 after a near 5-year run, and Lal himself slips into oblivion in 1967, precisely when the global campaign was being reinvigorated. While Lal's centrality is undisputed in the mid-1960s, we have in the 1964 committee another Indian participant, Dr. A.R. Rao, and I've highlighted the names of the Indians in blue. And while you rest your eyes on the names of these members, I would point out the importance of Dr. Ayagiri Ramchandra Rao to the global campaign. Rao was then with the Infectious Diseases Hospital in Madras, where a series of smallpox studies were being conducted. Research was conducted on the infectiousness of early smallpox, the dissemination of the virus in air, comparison of freeze-dried and liquid vaccines for revaccination, and the prophylactic value of gamma globulin, and so on. Clinicians from Northern Europe and Northern America, Europe, and other parts of the world flocked to the infectious diseases hospital because we must remember at this point of time that the disease had been eliminated from large parts of the Western world, and it was only in Madras that clinicians could actually see cases of smallpox and learn about clinical diagnosis of the disease. Also, the most virulent form of the disease, variola major. Almost all of this research was conducted in multinational teams. So we have American and British scientists working in Madras, funded by the WHO, and publishing their findings in the official publication, the WHO Bulletin, which also meant that this research was widely disseminated. Rao published with his Indian colleagues in almost every single Indian medical journal as well. Interestingly, a medical research program was initiated in the WHO in 1958 with American support and financial backing. This 5-yearly report of the medical research program names the smallpox studies in Madras as the only collaborative project on smallpox. Although it must be admitted that smallpox was not really a critical priority research area for the WHO at this point. What I want to emphasize is that this collaboration did not merely thread through scientific bureaucracies in Geneva. We have a longer history of collaboration. For example, in the 1953 annual report of the Director General of the WHO, we have a reference to collaboration between Hooper Foundation of the University of California and Indian public health officials in New Delhi and Madras in 1953. While I have not been able to trace the trajectory or the entire logistics of this research, what I would like to point out, drawing from existing work on cancer research in the 1950s and 1960s, is that collaborative work among institutions of the Global South was not all that uncommon, and also it was funded through local philanthropy. Shifting gears slightly and returning to Rao, Rao participates in the important 1968 Committee on Smallpox, which produced a second scientific report. This report came after the 1967 declaration of intensified phase, and therefore Rao's career in this manner straddles both the pre-1967 and the post-1967 so-called intensified phase. It also straddles both research and administration because Rao at this point was health officer of the Corporation of Madras. In 1972, he published a 300-page textbook on smallpox describing his experience of working in the campaign as well as his clinical research. This work was primarily conducted in the state of Madras, which eventually became the state of Tamil Nadu, which had the best results from the national smallpox eradication campaign. It is well known that by 1967, smallpox had been greatly reduced in Madras, and this is acknowledged in almost all the official organizational histories and institutional histories of the WHO. In 1967-68, Rao also trialed the much celebrated surveillance containment strategy in the state of Madras because there was a small outbreak and it was contained as a result of applying this strategy. So Madras thus becomes the center for first embracing as well as experimenting with the surveillance containment strategy in India. Rao's name is inscribed in the global campaign. His is the first photograph that appears in the official history of smallpox eradication, the Big Red Book. His clinical classification is drawn upon. You see reference to it in almost every page of the early chapters. And he was also a reviewer of the Big Red Book, which is 1,500 pages. My foregrounding of the names of Indian actors is not an attempt at a proto-nationalist rendering of the global campaign. Decentering the global West does not mean creation of new centers in the rest of the world. Professor Sanjay Bhattacharya, in his comprehensive study of the Indian program, for instance, has pointed out the tensions within the Indian public health bureaucracy which affected the ground level campaign. But we could ask, for instance, how has the national history been written into global histories of eradication? We could ask, for instance, why have the histories of research never been put in conversation with ground-level campaigns in localities like India? While recounting these instances of purported borderless intellectual exchanges, one could query if there were any limits and new boundaries in this flow of information. One could be struck by the hypervisibility of the Indian campaign vis-a-vis the campaigns conducted by US aid officials in locations like Iran and Bolivia in the 1950s. There were a number of pilot projects conducted on smallpox in these regions. Commemorations are also moments of critical reflection. As we continue to question the global asymmetries in health, we must also challenge the asymmetries in our global histories. We can do this conceptually by asking new questions, and methodologically by reaching new sources: grey literature, oral histories, private papers, and locally circulating medical and scientific literature. This is the Indian Journal of Public Health publishing a major study on smallpox in Madras in 1959. A final comment before I conclude. My attempting to write such a history has been made possible through my own displacement from a teaching-intensive academic institution to a global center for health histories, all made possible by the Commonwealth, the CGHH, and my Indian employer, SNDT Women's University. A big thank you to all. Thank you.
First of all, Sandra, I'd like to thank you for inviting me to participate. It gives me a chance to let off some steam I've been storing for many, many years. It's very complex, the topic of logistics. In a sense, I can tell you a few anecdotes about what happened, what didn't happen. What I've thought about a lot, it's an incredibly exciting thing to be in Geneva working for D.A. Henderson and with Dr. Rita. It's a happy happenstance that I got to be in the position where I was. I am originally from Canada, and I was wandering around Europe when I applied for a job with WHO, and I got hired to look after the recording of cases. We had a computer in those days with a huge reel, and went through recording numbers. Logistics, let's see, how can I try and get this in order in my mind? And what I'm doing or plan to do with this time is looking to the future. What did we learn? What did I learn from dealing with logistics that would help direct, or what I would like to have happen with WHO? So one of the things that's essential was WHO was essential for coordination and communications, for the eradication of smallpox as a neutral agency that could go in. Now, for the numbers and the details, we have the Big Red Book, which I hope you're all aware of. It is 31 chapters and 1,500 pages covering clinical features, epidemiology, eradication, certification of eradication, and lessons and benefits. It's complete. Anything you ever want to know about smallpox and those areas, that is the Bible, the Big Red Book. Now, if we look for, to set the scene, look for public health general considerations. We have three aspects. You've got prevention versus curative, external financing versus self-sufficiency, vertical management versus horizontal integration. So within that, the key strategy was surveillance containment of outbreaks. And this was needed the support in order to maintain surveillance or introduce surveillance. We had to have mobility of the staff. You had to, if you didn't have a vehicle or some means of transport, you weren't going to get the outbreaks contained. So it was the key. I had a very trying evening in Dhaka when I was out helping with the administration of the office there, that they were going to get 4 new Land Rovers, and on the basis of that, they felt that they were going to lick the last case in Bangladesh. But unfortunately, this wasn't the case. And I was virtually on my knees begging them, got to put in some backup for the vehicles, because you're not going to get your way through. So they said, no, it'll be all right, DA and Stan Foster and music. And I said, okay, but I really wish you'd take out some insurance, put in some backup, some spare parts, get a mechanic. And they said, no. And sure enough, there was another outbreak, and there had an emergency operation was mounted. And then I was there waiting for the mechanic to come. We got a mechanic from Oxfam who was really brilliant. I met him at the airport, got him off the plane, got him into the guest house, and there in the front yard was a Land Rover, immobilized. Rodney got his toolbox out and pulled the head on the Land Rover, and then looked very proud of himself. And I said, Rodney, that's really good. I hope you enjoyed that, because that is the last time you're going to touch the vehicles. You're going to ensure that other people look after the vehicles. And we mounted a whole campaign, and Rodney did a brilliant job. And he later went to Somalia, but that's a second story. So that was a problem solved there. Now, the second problem we had was in Bihar, and they were still having outbreaks there. And there was a problem doing the surveillance because of the vehicles. The young doctors we had, they were in charge of a vehicle and were given money to maintain it and put gas in it and whatever. But they were nervous about not doing, being careful enough with the money. And so they would save up all their problems and they would come to Patna once a month, and it would be inundated with vehicles wanting to be serviced and looked after. So this was a problem. So I came up with a solution. I was in charge, well, I was in contact with the people who were servicing the vehicles, and they gave me a list of all the common things that need to be looked after with the cars. And I put a price on it. I handed it to the people and say, okay, look, when your driver says you need something doing, there's the price, go ahead. And never had a problem again for the monthly meetings. So it was a happy event. I was very pleased with the result. So we have the transport be provided by the vehicles, the logistics to keep the vehicles running, and we had all kinds of transport. We included helicopters, camels, boats, and motorcycles. And this is not an obvious pulling together this thing. It was finally accepted to have the administrative support, and the Oxfam provided a mechanic for Dhaka and a price list for Bihar. Problem was solved there. We used helicopters in Ethiopia for surveillance and containment. It was necessary because of the rugged terrain and nomadic population. There also just happened to be a war going on between Somalia and Ethiopia in the Ogaden Desert. We only lost one helicopter with a grenade, but otherwise it was very useful. One of the things I got involved in was a helicopter contract, and was a multi-million-dollar affair. And I asked DA if I could go to Canada and negotiate with the company for a longer term. So that turned out to be very successful. I said to the Larry Campbell, who was the president of the company, saying, would you look after seeing that I get the best price, because then I can go back to Geneva and sort of strut around and say I got a really good price. And indeed, I did get a very good price. In fact, it was so good that I was called up to the director of budget and finance and saying, how did you do this? Because there was a big difference in value or price between an American firm that was flying helicopters for the Onchocerciasis project. And the director, instead of patting me on the back, was actually a little bit disturbed, because he was, of course, embarrassed by the whole thing, that he didn't get that good a price, or was responsible for that. So just when we thought we were on to the last case in the world, in Ethiopia, outbreaks were reported in neighboring Somalia, who incidentally, with whom they were at war, No staff was hurt, but one helicopter was blown up. No resources were available for a smallpox eradication effort. Everybody was at war. No vehicles, no staff. One of my colleagues said to me, "John, there is no Santa Claus." I said, "I cannot accept that. We've got to do something." So I spin another little tale for you. When I was in high school, one of my classmates became a fighter pilot for the Canadian Air Force. And he had a girlfriend that went from the West Coast to the East Coast on weekends. He would take a fighter plane and fly it because he had to put in hours. And I said, "Gee, he has to put in hours. How about we could get some airlift from the Canadian Hercules, which they can fly somewhere?" Well, I found eventually that it was UNICEF had some reconditioned Land Rovers in Copenhagen, I think it was, and I managed to get the Hercules going, but it took organizing, having Somalia declare themselves a disaster area. So there was a telegram went out and said, "Send this to us." And then they went to an emergency area disaster relief. And we got, within 27 days, we had 7 Land Rovers, I think it was, and 3 flights of Hercules and money from Sweden. So we had $250,000 in 27 days. And that was, we got the transport, we got the mobility, and brought Rodney from Bangladesh, had him come and look after the organization of people. And indeed, we got smallpox eradicated. And the, if I can have the slide, that's Ali. That was the last case. And we were in the process of making a film, a documentary, when we got the last case in the world, naturally occurring case. So that was it for the groundwork. And then it was a matter of certification came on after that. How are we doing for time? 5 more minutes? Okay. So I've got one last thing about lessons for promoting public health globally. What I've picked up from reflection and practical experience. What I find that WHO needs to ensure that technical input to countries is balanced with support to the management capacity of ministries of health. It's really big gap. WHO needs to be the focal point to coordinate input to countries from all sectors, UN agencies, Global Fund, etc. So somehow we need to use WHO. They are unique. They don't have much money compared to the Global Fund or Gates, but they got the technical capacity and they need to develop management capacity, because this is what the countries that I've seen need. They need the support to how to deal with the coordination. Go back to coordination again. It's a coordination of the input from various agencies. It's control of the multi-sectoral financing. And I had a slogan for that. It was, we need to call for a rapid response to long-term development. And we need a coordination of multi-sectoral finance. And we need to have management and sectoral input. That's my wish list. And I thank you very much.
So comments, questions, please.
But you've not told us anything about the disease itself. Can you give a bit more detail on what the disease is? I know you get spots, but it's a bit debilitating. Can you tell me a little bit about it? Oh, sorry.
Well,
Yes?
okay.
Go ahead, John.
I can show you a picture of it in the big red book here. Oh, damn, I didn't bring the other. Well, it's a virus. It's transmitted respiratory. Oh, hang on. You see, I've been referring to this quite often. Little tag. Oh, well, never mind. Really, it needs picture. It's a virus. It has pustules. It's sort of like chicken pox on steroids. Here. Now, can you see that?
Oh,
Does that come
yes,
through?
Yes, yes, I can see. Just yes, I can see. Yes, yes.
Okay, so you have the pustules forming, and when you're exposed, you're on an incubation period of about 14 days, and there's a variola major, and then there's variola minor, the difference being the severity of the disease. The variola major, you have a death rate of about 26% of the cases. And what it is you get the pustules forming, and they just causes all your internal organs to collapse
Oh gosh.
if you live through it. If you can vaccinate during the incubation period, and that usually avoids dying. The variola major was in India and Bangladesh, and as opposed to Ethiopia and Somalia, where it was variola minor for a large part. And there, the death rate was more like 1%. Now, I'm sorry I don't have a better picture. I have you have more pictures. So,
Yeah, but
well,
in a really bad case, the whole body would be covered. So,
It had a centrifugal
That's right.
distribution you could use. So it's at the extremities and on the palms of the hand. And there's a differentiation between measles and syphilis.
Yeah, there's a question.
Hi. I was wondering how highly you rate the risk of accidental or deliberate release of smallpox in the future, and maybe you could also comment on increasing access to information about genomes and technology where viruses can be recreated. Whether in future that will be more of a danger with
No,
smallpox.
no danger. It's under lock and key. And in fact, there's a Canadian lab I read somewhere recently had actually, they've done an analysis of the genome. So they've got that looked after. And I think they created one virus. But it's been a real discussion about, do you eliminate that last sample of virus as killing a special species? It's an ongoing problem even now, trying to resolve, should they destroy the the virus or not? So we just wait and see. There's, I've got another anecdote which has always amused me. We had, when the campaign was full bore, they had a meeting for the biological warfare subject, what to evaluate, what to do, what to recommend, what would happen, or what were the possibilities. And there was a reception, and I was talking with this gentleman who was very large and had a very military bearing. And I said, tell me, what do you think about using our smallpox being a biological warfare agent? And he looked at me and he said, no, 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 we have things that are so much better. Yeah. I said, how nice, how reassuring. But I'm, I'm confident myself that I'm not going to run out and get vaccinated.
Thank you. Any more comments, questions? Are there any questions from Slido, I wonder, from Copenhagen? There's no idea? Yeah. I mean, one of the questions I have often wondered is during the 70s, when you were in charge of logistics, you had the oil crisis. Did that affect the program at all? I
No,
mean,
no, no.
no. Is that because you had stocks? Where did the petroleum for all these vehicles come from? I mean, was it provided by
It
India, by the
was
country?
available. I never had a problem of shortages. was always fuel available.
Right. Okay. Okay, so we have questions from Copenhagen, where our colleagues are running Slido. So the person who's asking the question chooses to be anonymous, but asks, there is much resistance to smallpox vaccination. How can institutional resistance and geographical concerns of covert foreign policy agendas be addressed?
Well, that's a problem with measles as well,
Yes.
having outbreaks in New York. You can, well, some countries make it obligatory that the child cannot go to school without being vaccinated. That's one possible control. We had, during the campaign, there was a movement that was insisting that smallpox vaccination was transmitting AIDS. Well, you know, it takes everybody, all types.
Then a second
It's-
question
it-
also.
it's a
Sorry.
political problem, really. You know. It's
Right.
hard to make it against the law to refuse vaccination. How do you deal with it? It's a problem. Luckily, not a big one.
And then another question, again anonymously, is how can we move from passive acceptance of vaccines when vaccines are provided or pushed to increased active demand?
Well, this is a problem of education. This falls under the category of prevention. There are various religious groups who object to vaccination or refuse vaccination. It's, well, I really don't know. All I can do is, when I meet someone like that, is say that they want to let their children die. It seems silly to take the risk. When you look at the chances and the percentage, what is the risk of having a complication? There are some complications, but it's sort of 1 per million vaccinations.
Namrata, would you like to say
Yes,
something?
I would like to comment really on a question that is often received on resistance to vaccination. And also this particular question on actively seeking vaccination versus funders or the state pushing agendas of vaccination. So this whole question of cultural resistance to vaccination needs to be studied historically, I would argue. For instance, if you look at some of the early pilot studies that were done, and I refer to the pilot projects, the 16 pilot projects that were done in various districts, what was observed was really startling. Apparently, the resistance came to vaccination not really from the rural population, but it was stated very clearly that the educated sections, government officials, and the medical officers were alarmed that why is it that government officials were resisting vaccination. And when they dug deeper into all of this, there was a range of concerns not particularly related with religion. For instance, in the agricultural season, it could be you would be out of work for many days because of the pain on your arm. It was also who was vaccinating you, who had access to the vaccine. For instance, if you look at some of the memoirs of people, and when of people who were looking at evaluation of vaccination campaigns, and they would go into villages asking if they had seen a vaccinator in the area. And the person would probably respond, no, I've never seen a vaccinator. And the official would be alarmed, because here we are in the middle of a campaign and this person says we've never seen a vaccinator. And when this whole information about who the vaccinator is was disaggregated, it was realized that this vaccinator probably came from a lower caste background. And therefore, it was mainly he at that point of time, he never actually had access to upper caste quarters. And therefore, the upper caste community and households had never seen a vaccinator. So there are these complex stories that need to be unraveled about what we see as resistance and what we see as acceptance. And of course, as Sanjay has pointed out several times, in the middle of an outbreak, people would come running to get vaccinated. They would bring their young children to get vaccinated. Resistance was also seen with the rich children, because there was this strategy to vaccinate infants at this point of time, and mothers would really not want little children to be hurt. So resistance really needs to be disaggregated and needs to be understood in its own terms. And we must also remember that this was a major campaign launched in India without any legislation. There was legislation in some parts of the country, but despite pushing from lots of public officials, the Indian government never imposed compulsory legislation. So you must understand the complexity of this campaign, especially in countries like India, vis-a-vis countries like the Soviet Union, where vaccination was compulsory by legislation, and in other contexts as well. So I really wanted to give my 2 bit on this issue of resistance.
That being said, I mean, you did get rid of smallpox, so there was the proof of the pudding.
Yes, absolutely.
There, each situation has to be dealt with, and responsibility given to the people running the campaign, and their various tactics or strategies are employed to do it. And it's a tribute to people that they believed in vaccination, in eradication, and loved devoted staff far more than the people who were dissenters. So it's a congratulations to the country as such.
Thank you. Sumit?
Yeah, I mean, an interesting episode here, which for the rest of the world, is that mid-70s till early 80s, so like the 70s, is also a period where another very controversial health program was going on in India. That was the family planning program. And if you see them, so there is at one end, which we may say a very coercive program, where, and actually at the village, like the health workers, the health assistants, the ANMs, and the same people who were actually pushing sterilization campaigns. So you think that, and thinking of the northern Indian belt, like where Bihar, UP, and these states where, so it's a very interesting dichotomy, if I would say, where at one hand you are trying to push an eradication program, on the other hand, your primary health workers are mostly engaged in a coercive campaign, and there is this kind of conflict within both programs being implemented, let alone the general emergency which sets in 74 onwards. So I think this is a very important political question under which this builds in, and the way these two programs, and it's probably interesting to know how did the crosstalk happen, or what these reconcile, like a disease eradication program going, and then there is the family planning sterilization program. So
Yeah, maybe a very quick comment and sharing as well on this. It's very interesting. This question came on foreign policy considerations. I would say even domestic policy considerations are important, because as you point out, at this point of time, there's emergency, there's a family planning program, which is seen as almost synonymous with the emergency. And sharing an anecdote, one of the memoirs recounts that this smallpox eradication worker went into a village, and they found that the whole village was deserted. And they thought, how is it that the whole village is deserted? And apparently there was a young boy, they caught hold of him and they asked him, and they said, everybody ran away because we thought you were part of the family planning thing. But then they're all coming back because they saw the jeep, and smallpox gave its own jeeps with their own, insignia. And the people saw that it was the smallpox jeep and not really the, so the public health workers and the eradicator was coming in talking about smallpox, and the people were slowly streaming back. So, the symbols and signs and, even the jeep with the smallpox thing on its body indicated what the program really stood for in the eyes of the villager, in the eyes of the receiving population. So it's very interesting as to how symbols were communicated, how insignia was communicated, and how the program itself was seen, and how you see that people at one point joined these two programs, but could also distinguish between the constituencies that were approaching them and probably receive them at different sort of levels.
So it's idea of verticality helped at some point. So it's an example that it's not always comprehensive, integrated, horizontal program. In this case, maybe the verticality was kind of...
Yeah, well, in some ways, but we also have instance of the malaria workers also chipping in, and also the family planning people chipping in, especially when they were doing these surveys of smallpox scars and so on and so forth. So really, on the ground, as some historians will say, each country was messy in its own way. So probably we need more. I mean, this is my only plea for more national stories to come in to sort of populate the global story as well.
John, would you like to make some closing comments?
Well, it's the individual. It really is something that had to be dealt with at the local level, and it is problematic, but usually by contacting a village chief or respected person, and they would have special efforts to convince people that it's better to get vaccinated and not get smallpox than otherwise. And it's this, as we mentioned earlier, there's the problem with measles. It's current happen. It's really up to the individual to be dealing with and custom-made solution to the problems. I have had my children vaccinated, I can assure you.
Well, I mean, one of the things I heard from many WHO colleagues was that when people were worried about the safety of the vaccine, they would often ask the vaccinator to vaccinate themselves before they accepted the vaccination. So people like Larry Brilliant, for instance, told me that he'd vaccinated himself multiple times in order to convince people that what he was offering them was a safe product. So perhaps that is where we should thank our two wonderful speakers. Thank you, John, for joining us from Geneva. And thank you, Namrata, for speaking. And I hope people keep in touch with the speakers, with questions, with comments. Please do. That's the whole point of these events, so that we create networks, connections. It's not a one-off event. So please email, please get in touch. And thank you for the book.
Thank you very much. I badly need it.
John, thank you so much. And thank you to your son
Pleasure.
for loaning his computer to you.
Yeah.
Thank you.
Thank you. Thank
Have
you.
a good day.
Thank you all.
All of you.